Good afternoon. It is Thursday, December the 11th, 2025, and this is a Protect Our Province BC briefing on Science as a Candle in the Dark, a discussion about measles, HIV, and COVID-19. I am Dr. Susan Coe, a family physician working in Richmond, BC for 32 years. I am a clinical associate professor at UBC and a member of Protect Our Province BC. Protect Our Province BC is a nonprofit grassroots organization consisting of doctors, nurses, health scientists, and community advocates striving to keep the people of British Columbia safe by sharing accurate scientific information about COVID-19 and other diseases. We also advocate for the BC government to do more to protect the health and prevent chronic disease and disability for everyone who calls BC home, starting with the most vulnerable among us. We begin by respectfully acknowledging that we are broadcasting from the traditional, ancestral, and unceded territory of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations. We are grateful to the Indigenous peoples who have cared for these lands since time immemorial. As settlers, we commit to do our utmost to hold the Truth and Reconciliation Commission and work towards the 94 calls to action. Today, we are very happy to have join us for this interview three remarkable physicians, Dr. Filiatrault, Dr. Victor Leung, and Dr. Julio Montaner. Dr. Filiatrault is a retired emergency physician. On March 7, 2003, her emergency department team quickly isolated Vancouver's first SARS patient, shielding Vancouver from a major SARS outbreak. A past member of Protect Our Province BC, she's now part of the Canadian Aerosol Transmission Coalition. She's a co-author of the May 2025 Canadian Health Watch article titled, "Measles Doesn't Care About Your Politics." Dr. Julio Montaner holds the UBC and St. Paul's Foundation Chair in AIDS Research. He is a UBC Killam Professor of Medicine, the Executive Director and Physician-in-Chief of the BC for Excellence in HIV/AIDS, and UN AIDS Special Advisor on HIV Therapeutics from 2014 to 2017. Dr. Montaner played a key role in development and implementation of the highly active antiretroviral therapy, HAART, as a modern standard of care for HIV disease. He then pioneered treatment as prevention, using HAART to simultaneously stop progression to AIDS and death and HIV transmission. Based on his task strategy, his proposal for the 90-90-90 by 2020, followed by the 95-95-95 by 2025 target that was formally adopted by UN in 2015 to end HIV as a pandemic by 2020. Dr. Victor Leung is an infectious disease physician and medical microbiologist. He has medical expertise in preventing and controlling hospital-acquired infections and implementing programs to optimize antimicrobialization. He's a clinical professor in the Department of Pathology and Laboratory Medicine at UBC. Over 30 years ago, Dr. Carl Sagan, American astronomer and planetary scientist, had a foreboding of a demon-haunted world which would reject the enlightenment of science and return to superstition and darkness. We are seeing this right now with the falling rates of childhood vaccinations and a re-emergence of diseases like measles. The COVID-19 pandemic has further led to public distrust of science fueled by misinformation coming from the very public institutions that should have garnered trust. We are seeing this in the rising cases of HIV globally, when the goal of global eradication seemed very close to our grasp. Our first guest today will be Dr. Filiatrault, and we will discuss the measles crisis.
Good afternoon, Susan and everyone.
Thank you so much for joining us today, Dr. Filiatrault.
My pleasure.
So, Dr. Filiatrault, what we are seeing, the news headlines have been dominated by the rising cases of measles in the United States, with 1,828 cases and 3 deaths as of December 2nd, 2025. Here in Canada, we now have more cases than the US, which has 10 times our population at 5,298 cases as of November 29, 2025, with 2,394 of these in Ontario and 1,975 cases in Alberta. Of these cases in the US, 92% have occurred in unvaccinated people, whereas in Canada, 88% of these cases have been unvaccinated people. The situation was so serious that Canada was informed by the Pan American Health Organization that it's lost its elimination status last month in November 2025. But there seems to be very little action taken by governments, both provincially and federally. So, Dr. Filiatrault, is there a measles crisis currently in Canada?
Absolutely. There is a measles crisis in Canada, but measles is only one part of the crisis. Measles is the canary in the coal mine. So it is the most contagious infectious disease, or one of the most contagious infectious disease. So that's the one that we could see large outbreak as a result of it. But it's more the childhood preventable, vaccine preventable childhood disease that is the crisis that is happening right now, with more and more parents and individuals turning down vaccination. It's not just measles that's making a comeback, it's also whooping cough and other childhood diseases.
So Canada, we eliminated measles in 1998, and so what's happened to get us here again?
What's happened didn't just start in 2020. Even in 2015, the WHO was raising the alarm that the rate of vaccination was going down across the world, and there was fear that the eliminated childhood diseases such as measles would make a comeback. And with the pandemic in 2020, what we saw is really a rise in anti-vaccine group advocacy. And on top of that, social media added oil to the fire. So it really spread. And it got us where we are right now, where we have now measles spreading in Canada when we had eliminated it in 1998. And right now, we're exporting measles cases to the US. When you look at the CDC data, both Mexico and Canada are spreading measles into the US as well, and where they have their own challenges.
Yeah, it's very concerning. Why does measles need to be taken seriously and it's not just another cold virus?
Like I said, it's one of the most contagious infectious disease. It has the ability, one person who's infected has the ability to spread to 12 or 18 other individuals that are not protected through either prior infection or vaccination. So you can imagine exponential growth with these kind of numbers, where one person infects 12 people, let's say, and these 12 people go on to find 12 other people that they each infect, and you end up with a massive outbreak. If you look at it another way, the attack rate. So if you have a child that's not immunized, that's going to school in a community where there's poor uptake of the measles vaccine, that infected child will infect 90% of his or her classmates that are not protected by vaccine or prior infection. So it's extremely contagious, and in the situation we find ourselves in right now, where we know that many of the infectious disease that are airborne thrive in unventilated schools or poorly ventilated schools, this was predictable what was going to happen. So you've got the virus itself, and in terms of its ability to spread, and then why is it not just a cold? It's the seriousness of the illness. So when you look at acute complications, you've got about 10% of children that may develop an ear infection, and that can lead to deafness. You've got 5% of children who will develop pneumonia as a result of a measles infection, and that's the primary cause of death, is pneumonia in acute measles. And then you've got 1 in 1,000 children that will develop a brain inflammation that we call encephalitis. So you have brain swelling, they can have convulsion, and it can lead to death and brain damage if they survive. And that was what happened to the daughter of the author Roald Dahl. when she was infected in 1962, a year before the vaccine came out for measles. And then you have people who are infected when they are pregnant, if they haven't been immunized, and then they pass on the infection to their unborn child. So you end up with premature labor, spontaneous abortion, or as we saw in Canada, 2 cases of congenital measles in the babies that were born, and they subsequently died. And then when you look at the stress on resources in a well-developed country, about 10% of people that get measles will get admitted to hospital. Obviously, in other countries, that numbers can be higher. And then in terms of dying, you're looking at 1 to 3 children dying out of 1,000. So that's the acute complication. But then you've got the subacute complication, and we're going to get into that a bit later, immune amnesia. So getting measles sets you up for more infections for the next 2 to 3 years. And then the chronic complications, one of the things we learned with SARS-CoV-2 is that this blood-brain barrier that we learn about in medicine is not as impermeable. And with measles, you can get what's called SSPE, or subacute sclerosing panencephalitis. So the child recovers, and 10, 15 years, it's variable when, they suddenly start having significant impairment, and most of them go on to dying with if you want, a reactivation of the infection in the brain.
Yeah, I know there's a child in California who died of this in September 2025. And I understand that the child was too young to get the measles vaccine, but caught the disease very young, and then ended up dying many years later. Right? So very, very sick.
And it's that delay that makes it difficult, because it's a sudden behavior change, a sudden personality change, and then people in the first presentation can be diagnosed with mental illness, and we see that nowadays playing out with long COVID. So they get misdiagnosed, and then suddenly things get worse to worse. There's about 4 phases of this disease, and if it's not picked up early, which is hard to do, it's basically essentially fatal. You end up with a vegetative state, and then complication of that vegetative state, and often dying. And it's actually quite heartbreaking, because you have people that were thriving, doing quite well, and all of a sudden they can't function, their memory's affected, they get cognitive impairment, and seizures, motor disorders, tics, and so on, and it goes downhill from there.
Yeah, it's absolutely heartbreaking. Yeah.
And it gets to the point that what SARS-CoV-2 is trying to teach us is that it's not, one and done. You get an infection, you recover, and you're fine. There's also chronic disease as a result of viral infection, as we found out with lupus, MS, that can be triggered by Epstein-Barr virus, so the mononucleosis virus. And then I'm talking about SSPE, where years down the road you thought you were fine, and yet measles infection and ended up with brain damage.
Yeah, this is all very alarming. You also mentioned immune amnesia. Can you explain how measles causes immune amnesia?
Yeah, so it's actually fascinating in that the epidemiologists look at outbreaks of measles and followed what happened after larger outbreaks of measles in communities. And they found that large outbreaks of measles were followed by a rise in infectious disease illness after these outbreaks. And so what they speculated is that a measles infection predisposed you to be infected with other bacteria, viruses, and other infectious diseases after you had measles. And it took years before they had the tools and they could prove their hypothesis. And so a group out of Harvard studied a population. So it was an international collaboration, and they studied a religious group in the Netherlands that didn't vaccinate children, but they weren't averse to do research. So they they worked with them and looked at a before and after measles infection in that community. And by then they had the tools to see that kids that had been infected with measles, their antibodies that they had before the measles infection drop anywhere from 10 to 70%. And these were antibodies to previous infection and antibodies acquired through vaccination. And so they could prove the hypothesis that when you get measles, it's your whole immune system that is impaired, and it's for anywhere from 2 to 3 years. And they also proved that vaccination didn't affect your immunity. And that's why when you look, Susan, when you look at the WHO statistic for their 50-year global immunization, they saved around 154 million lives over these 50 years, but 60% of the lives saved were because of measles immunization. Okay, so immunizing with measles also not only save lives for measles, but save lives for a whole slew of other infectious disease that would have killed these children had they not been immunized.
Yeah, I read that report. It said that 6 lives a minute are being saved every day, right?
Yeah.
From immunization.
Yeah.
Yeah, it's amazing. But, well, that's very alarming. So getting back to BC, in July of 2025, there's a press conference, and the BC Deputy Medical Health Officer, Dr. Lavoie, told the press that he thought BC was quite good because we had 84% of people vaccinated with 1 dose of measles vaccine. But on the same graph that he shared, only 67.8% of people were fully immunized with 2 doses, and 16% had no immunizations at all. So what percentage of immunization do we need for herd immunity for measles? And what's your opinion about what Dr. Lavoie said?
So instead of using herd immunity, I think we're better to talk about community immunity because it's more reflective of reality. And so for measles, you need 95% to vaccine. So 95% of your community should have had 2 vaccine. It's impossible to get to 100% because, as we'll talk later, not everybody can get the measles vaccine. It's a live attenuated vaccine, so certain population group cannot get it. So I think it's very misleading to say that BC was in a good place when you only had 84% vaccinated with 1 dose for measles. And you can't use the average of the whole province because what matters is your community, and if you don't have that number, it's the region, the health region, or the various regions that we divide BC into that matters. But using an average for the whole province misrepresents what is the real risk of measles spreading. And on that note, Michelle Gamage of the Taillis back in March interviewed me for an article that she wrote. And she basically looked at the data from the BC CDC from 2023. So that's accessible on the website, and it shows various regions, what is the rate of one at 2 years of age, how many children had 1 vaccine, and at 7 years of age, how many children had 2 vaccine. And basically the title of our article became BC measles vaccination rate is lower than in Gaines County, Texas, where there was an explosion in measles. So we really had nothing to be proud about in
Mhm.
BC. And in fact, we knew back in March that the measles outbreak in Alberta, with the amount of exchange that we had between Alberta and BC, that it was just a matter of time for it to spread to BC, particularly in the communities that had little uptake of 2 doses. So BC's northeast right now is where you have the most of the outbreak currently.
Mhm.
Back in the article, they were referencing that in 2023, you had only 74% of 2-year-old that had one vaccine
Mhm.
dose of measles. So you knew that you were way too low and that community would be at risk. And sure enough, that's what we're seeing.
So, Dr. Filiatrault, why are there now record numbers of parents choosing not to vaccinate their children against child diseases like measles?
You know, this problem with vaccine hesitancy and vaccine refusal is not new. So there's a very good article from 2015 by the WHO, and really it exposes to what degree this is a complex problem. And so there's no silver bullet or easy solution. And they talked about 3 C's, and I made it into a 5 C's. So they talk about complacency. The fact that many families have not seen measles before, have not seen some of the, we were so successful in the past with our vaccination program that they've become complacent. We don't see it, it's not a problem, doesn't exist. Well, this is all changing now. And so there's a level of complacency or public health suffering from its own success, if you want. And then there's an issue of confidence. So confidence in public health, confidence in the healthcare system that's really been eroded for some time, but particularly with the onset of the pandemic. And then you've got also the issue that we have with making it so hard for parents with small families to get immunized. So even to this day, there was a mom on Twitter talking about the difficulty of getting all her children having to individually book appointments in
Mhm.
order to get each kid vaccinated, which meant she needed to take off from work. So we haven't been responsive enough to make it easy for families with young children to do the right thing. And then there's really a problem of how we communicate. And as you and I have learned, science doesn't move the needle for many people. So we need to find, what matters to people and what matters to different communities. And I'll give you an example. I was in Tofino recently, and a friend related that a mom had 3 kids. She wasn't going to get them vaccinated for chickenpox until the friend said, well, you realize that if you don't vaccinate, you'll have one kid sick, and then the other one's going to catch it, and then the other one's going to catch it, and you're going to be off work a large amount of time. So
Mhm.
it was focusing for what would move the needle for that mother. And so
Mhm.
we've used a one message fits all based on science, and we haven't really tailored our message to the various community, be it religious, be it First Nations that have a lot of distrust with good reasons
Mhm.
for healthcare provider and the healthcare system, and we assume that we're the trusted messengers, but it's not
Mhm.
the case. It's really not the case. So it's a complex problem that will need a complex solution,
Yeah,
and
agreed. Yeah, agreed.
it's not a one shoe fits all.
Agreed. So, can you tell us about the Wakefield scandal and how this has contributed to vaccine hesitancy?
Yeah. So in back in 1998, Dr. Wakefield was a gastroenterologist who did research, and he was in England. And he basically published a now discredited case case report or case study and had, I don't know, 12 or 24 patients that were previously selected. These cases had autism, and he tried to push a hypothesis that the measles vaccine had caused the autism in these children. Well, a lot of parents of these children were actually suing vaccine company at the time. So really completely biased sample, and really misrepresented, because in fact the pathology he was doing, GI biopsy showing that the measles vaccine had caused inflammatory disease, which was linked to autism. And in fact, the pathology was not supporting even these findings. So it took, unfortunately, 12 years for the paper to be retracted from the Lancet, and for Dr. Wakefield to be, if you will, disbarred from the Royal College Society in England. And unfortunately, that was not the end of it, because by then a lot of parents had bought the messaging, and a lot of difficulty being able to change the narrative. And himself immigrated to the US and is now seen at rally of child health defense, and is doing more of what he was doing in the UK, except now in the States, with the results we see. And now we have the Health and Human Secretary, Human Services Secretary in the US being himself the founder of the Child Health Defense anti-vax group. And so things have just gone from bad to worse.
Yeah, it's a really unfortunate situation. So there's an article modeling study in JAMA earlier this year, and projected that vaccination rates of measles continue to be this low, that the virus measles will be endemic the next 25 years. Could you explain to us what that would mean?
Yeah, so first of all, we need to clarify what endemic means, because somehow people assume endemic means benign, and that's not the case. So endemic means that a disease is consistently present within a certain geographical location. So the classic example that's often spoken of is malaria in sub-Saharan Africa. So malaria is endemic, but it's not benign. Every year it kills almost 500,000 of children under the age of 5. So when you're talking about endemic disease, you're talking about predictable and located in a certain geographic region. And measles used to be endemic before we eliminated it in 1998. So I pulled out some of the history on measles, what endemic measles looked at, and that looked between 10,000 and 90,000 people infected in Canada in pre-vaccine era. And and then all the complications that I was giving were just compounded, because if you have more disease, then you're going to have more complications, more death, more admissions to hospital, more strain on the healthcare system, and more strain on society in general. And the cost of managing outbreak for public health, if you do a good job and have all hands on deck, is extremely expensive. So we don't want to get to endemic measles. It's the last thing we want to add with all the crisis that we already have. We don't need another one.
So in your Health Watch article, you had said that the responses on Ontario, Alberta, and BC provincial health to combat the exponential rise in cases has been a tepid response. So what should be done instead?
Yeah, so what I was alluding to is that both in, actually you could even say in BC, but certainly in Ontario and in Alberta especially, public health has been missing in action. It's almost like the politics has interfered with what we view as the gold standard of public health. Public health, if you look at it, it's about, promoting health, preventing illness, disease, and injury, and starting with the most vulnerable. And really in Alberta, if you look at the data, just like I showed in BC, all of this outbreak was predictable because they had an appalling rate of 2-dose vaccination. And when the chief medical officer of health, Dr. Mark Joffe, tried to raise the alarm and do something preemptively, he was shut down and basically told to stand down. And then you had the measles outbreak exploded, and it took, and he basically resigned. And after that, you saw he gave an excellent grand rounds on what happened with measles in Alberta and how all of this was preventable. And so we're in a situation that was completely preventable if politics and governments had not interfered with the real gold standard of public health, what its mission is and its raison d'être is. And so the article, what I was saying is that once you have measles, then it needs to be an all hands on deck approach. It's a crisis because it spreads exponentially. It's not a cold. It will kill people. And as we've seen, we have two children have died in Canada this year. And then we had one last year as well in Ontario. So if you let COVID spread and you get more and more cases, you're going to get more deaths. You're going to get more immune amnesia. So you're rolling out the red carpet for more infectious disease to come into your community because all these people that have had measles are now vulnerable for the next 2 to 3 years. It's like their antibodies have been wiped, in varying degrees.
Mm-hmm.
And then down the road, 10 years, maybe 20, we don't know, you're going to have somebody who's going to die of this progressive neurological disease because they hadn't cleared the measles virus in their brain. So we don't want to have endemic measles, and we should have been all hands on deck with this. This was obvious already in March, so we should have had vaccination, Vexilapalooza, whatever you want to call it, vaccination, SOS jab. It should have been done before schools reopened. And there should have been serious thought put in place to say, if you want your child to go to school while measles is spread in Canada, your child needs to have his or her vaccines before starting school. At a minimum for measles, because it's the most infectious childhood illness. And on top of that, it should have been a call to let's bring clean air in schools.
Right. And I've heard the same comment that, we need to get that high community immunity to 95% for measles protection. And some say that vaccines, like measles vaccines, are like masks. They're not just to protect yourself, but protect others around you, and especially the most vulnerable, right?
Yeah, because the live attenuated vaccine cannot be used by people who are immune compromised, and there's also a reason to be immune compromised. So you've got a whole segment of the population. I think it's something like 2 million in Canada that cannot get vaccinated.
Yes, we need to protect them.
So we need to protect them, and then you've got the babies that are born. And so the 0 to 6 months are reliant on their mom's antibodies. Well, if mothers are not getting immunized, there's no antibodies to protect these children, and they have the highest rate of morbidity and mortality if they get measles. And so, this approach of you do you does not work when you have measles, and period. It doesn't work with COVID, as we see, but it certainly doesn't work with the most contagious infectious disease that spreads through shared air. So At the very least, we should have followed the lead of Ontario and New Brunswick that have a vaccine mandate before you start school, and at least select it out for measles and then have a broader conversation. How can we bring other communities that are hesitant or refuse? How can we solve this problem in the long term? But in the short term, we could have been in a better position starting school in September because we knew this was coming.
I totally agree. So Dr. Filiatrault, thank you so much for this really interesting and in-depth conversation on measles. Really appreciate it.
Thank you for having me.
Our next discussion will be with Dr. Julio Montaner on HIV and the effects from the backlash of a rising anti-science world. So welcome, Dr. Montaner.
Thank you, Susan. Pleasure to be here with you.
First of all, Dr. Montaner, I'd like to thank you very much for all you have done for HIV and AIDS. Because of your work, millions of lives have been saved, and people with HIV worldwide are living active, regular lives. So thank you very much.
Thank you, Susan.
Dr. Montaner, I remember as a student in the mid-1980s, there was talk that infectious diseases especially was going to be obsolete because vaccination and the new antibiotics were so effective. But then HIV and AIDS crisis arrived and completely changed the entire landscape. Could you tell us what it was like working as an infectious disease doctor during this time?
Life was rather interesting in the 80s. As you know, I was at that time in internal medicine and respiratory medicine, and we were inundated by a number of predominantly young gay men who were showing at the emergency room at St. Paul's with pneumocystis pneumonia, which at the time was the cardinal manifestations of HIV infection. And unfortunately, it was associated with a very high rate of death. Eventually, most people who developed AIDS at that time, typically pneumocystis pneumonia, would die either from the pneumocystis pneumonia itself or in due course from other complications. We became interested in dealing with pneumocystis pneumonia. And I won't go into the details, but we were very fortunate that our research led us to new treatments, new preventive therapies. And eventually, by the mid-80s into the early 90s, we were in a position that we could basically control pneumocystis pneumonia. But unfortunately, the frustration was that we dealt with the complication. We could not address the underlying HIV. And so people would eventually go on to die from other complications in a rather sad succession of events. And that's part of the reason why I decided to refocus my academic and clinical objectives to develop antiretroviral therapies. And lo and behold, I guess we were successful. Lucky me.
So what happened to change the tide of the HIV/AIDS crisis?
So what happened was that we started slow. The first drug that became available for the treatment of HIV was, as you know, ACT or sadovudine. That emerged in 1986, 2 years after the virus was first announced by François Barré-Sinoussi, our colleague and former president of the International AIDS Society. So at the time, ACT was not in Canada. So John Rudy, the chairman of the Department of Medicine, was invited to organize the first clinical trial for the evaluation of the safety and efficacy of ACT as monotherapy in people infected with HIV. And he invited me as the younger sort of member of the team to participate in that research. And very quickly, we figured out that although the effect of the drug was time limited and not particularly profound, it did allow for some improvement in survival. And then a study that we did here at St. Paul's in collaboration with the late Mark Weinberg in Montreal allowed us to demonstrate that ACT actually would fail because of the development of drug resistance in a matter of weeks to months since you started the treatment. And since I am not formally trained as an infectious disease specialist, but I was trained in tuberculosis and respiratory medicine, my dad was a prominent TB specialist back in the day, I actually follow the tuberculosis paradigm to develop antiretroviral therapies. I always remember my father telling me or drawing the parallel between my experience with ACT and his experience at the time that I was born in the 50s, when he, being the junior member of the team, was given a lot of streptomycin and was asked to test streptomycin in his patients in the hospital back in Buenos Aires, in Argentina, where he was training at the time. He used to tell me the story where, we gave this to a patient that was very ill. That was clinical research in the 1950s for you. And they found that this person who had a TB meningitis almost resuscitated with the streptomycin, only to die within a matter of weeks later because of resurgence of the disease. And my dad used that as an opportunity to teach us how, by adding partially effective drugs, you could overcome the ability of the organism to mount resistance. And so very early on, I embarked on a quest to find other drugs to combine with ACT. And lo and behold, by 1996, I was, unbeknownst to the world, in possession of data showing that if we combined ACT, DDI, and nevirapine in individuals who were infected with HIV but not been treated before, and that was the key, you could actually get enough antiviral potency to suppress the virus to a level that it would not recover for as long as you continue to take the medication. And in July 1996, as you may remember, we were hosting the International AIDS Conference here in Vancouver, and we had the privilege of bringing to the world the huge breakout that triple therapy was. We call it highly active antiretroviral therapy. The Americans at the same time had shown a similar response when a protease inhibitor-based regimen with triple therapy was used. And so between our nucleoside reverse transcriptase-based inhibitor therapy and their protease inhibitor-based therapy, we were able to say, look, if you get enough treatment, you can shut down viral replication and you can get a sustained response. However, that was only the first, the second, the third breakthrough, call it whatever. Shortly thereafter, because we had the unique opportunity of roll out antiretroviral therapy in British Columbia very early on, because we had the news ahead of the rest of the world. And so we did roll out antiretroviral therapy, and to our surprise, because as you know, we monitor all potential outcomes obsessively here in BC, we came to realize that HIV viral load had decreased significantly in British Columbia as a result of treatment. People were living longer, and that was great. But at the same time, while syphilis, gonorrhea, and chlamydia were climbing in the province, HIV rates actually were declining. So this was unexpected and paradoxic because since there was no reason to suspect at the time that our treatments, which don't kill the virus, rather stop the replication of the viral particles while the virus continues to live in your cells, so that if I give you a transfusion from me, assuming that I'm infected and you are not, I'm taking medication and you get a kidney transplant or a transfusion from me, those cells will reawake on you because you're not taking the medication. And so the genome on that cells are able to explode with new virus and you become infected. And so the United Nations at that time had the position that treatment could not stop the ability of the infected person to transmit the virus. But we had data for the first time that showed, well, it may not stop it altogether, but look at what's happening here. More people alive with HIV, more syphilis, and less HIV. So we use a modeling approach to try to estimate the relationship between the number of people that were on treatment or the number of people that were virologically suppressed and the missing HIV infections. And we were able to show over a few years that for every 1% increase in antiretroviral therapy coverage, you saw a 1% decrease in HIV incidence or HIV new infections. And so with that, we postulated that treatment not only prevented morbidity and mortality, but actually prevented morbidity, mortality, and HIV transmission with a very high level of efficiency. And as a result of all of these, the treatment would become cost saving. And that basically revolutionized the whole thing. We call this treatment as prevention. We managed to present the data to Gordon Campbell, where he was the Premier of British Columbia. And within that meeting, in a matter of less than half an hour, he actually agreed to launch a pilot of treatment as prevention in British Columbia, and the rest is history.
Those sound like really exciting days, and it's really fascinating hearing you explain that. I understand the United Nations has adopted your treatment as prevention for global control of HIV/AIDS in 2015. But what about BC and the rest of Canada?
So what happened was that in 2008, I became the president of the International AIDS Society, and I really used that podium to help me advocate for the expansion of treatment and prevention to the rest of the world. And I was fortunate enough that in 2010, Michel Sidibe, an individual who had been previously the head of UNICEF at the United Nations, was appointed as the incoming head or executive director of the United Nations AIDS program. And so, since I was coming out of my presidency of the International AIDS Society, I was working very closely with the United Nations. I invited him to come and visit Vancouver in 2010 to show him the impact that treatment prevention was having. He came here around March or April at the time of the Winter Olympics, and we had a fantastic meeting. The premier showed up, the minister showed up, a whole bunch of academics came, and we were able to convince Michel Sidibe that the decrease in morbidity, mortality, but more importantly, the decrease in HIV transmission and the cost savings that we were seeing in British Columbia could actually be duplicated in the rest of the world. He was so impressed that from British Columbia, from Vancouver, he wrote a letter to the partners in the United Nations agencies saying, as of now, we need to change our approach and do, as Vancouver is doing, treatment and prevention for all people infected with HIV. And so we embarked in a campaign to do that. He asked me, when I stepped down from the IAS presidency, to serve as the special advisor to the United Nations on HIV therapeutics with a specific purpose of advancing treatment and prevention as the new strategy. And a few years later, he came back to me and he said, look, Julio, something is not working. I just came back from meeting with the president in South Africa. I was riding the elevator down with Matusaledi, the Minister of Health, and I asked him point blank, why is HIV out of control in South Africa? Aren't you doing what Julio is doing in British Columbia? He says, the minister said, yeah, no, we're doing exactly the same. We have testing, we have treatment, we have support, everything. Everything that Julio is doing, we're doing it here. And so Michel asked me, why is that they're doing what you're doing and it's not working the way it's working here? Mm-hmm. And Michel, not being a clinician, had a difficulty understanding the difference between BC and South Africa at the time. And I said, look, Michel, it's very simple. What happens is treatment and prevention is like a philosophy, like a religion, like a recipe, if you want, but the portions are not being fully described. And so people are putting a little bit of this, a little bit of that, and the mixture is not coming out right. And I said, give me a little time. I'm going to go back to Vancouver. I'm going to work with the team, use our data to give you metrics that you can apply to the rollout of antiretroviral therapy globally to sort of predict where do you need to be at 5-year intervals to actually bend the curve of the epidemic towards extinction or elimination. I don't know if he believed anything I said at that time. I said, Julio, please do, because we need this desperately. And so I came back home, and I was working with the team, Viviane Deslim, and a bunch of my colleagues here, all of them very much involved in all of this work. And what we did is we started by defining what we would like to achieve by the year 2030. And so we said, well, given the circumstances, we would like to eliminate the pandemic as a pandemic threat. And for operational purposes, we said, okay, let's arbitrarily decide what is this going to look like. And out of my hat, I said, well, I would like to have a 90% decrease in morbidity, a 90% decrease in mortality, and a 90% decrease in new infections by the year 2030. And we said, does it sound good? And everybody said, yeah, that sounds great. I mean, if we achieve that, it would be fantastic. I said, okay, good. So let's take the BC data now and then back calculate if you were to roll out the strategy in 2015 at a global level, using 2010 as the baseline for your epidemiological numbers, where would you need to be in 5-year intervals, so 2015 to 2020, 2020 to 2025, and then 2025 to 2030, so that you've achieved that 90% decrease in morbidity, mortality, and transmission. And lo and behold, the results showed roughly that if by 2020, having launched the new strategy in 2015 at the global level, if by 2020 we had at least 90% of people globally diagnosed, and at least 90% of those on antiretroviral therapy, and at least 90% of those virologically suppressed, we would bend the curve towards the goal that we define. If in addition, by the next 5 years, we move that from 90, 90, 90 to 95, 95, 95 by 2025, then we consolidate that trend. And of course, by 2030, we would need to be close to 100, 100, 100. It may be impossible, but close is good enough. We went back to the United Nations, we presented that to their boards, and then we took it globally. We got consensus, we took it to the African Union and then to the United Nations proper. And in 2015, we got unanimous consent for the 90, 90, 90 by 2020 and the 95, 95, 95 by 2025 to become the formal global strategy under the Sustainable Development Goals. And long and behold, this was ratified by the government of Canada in 2015 within actually 2 weeks of Jane Philpott becoming the Minister of Health. And my acknowledgement to her and Justin Trudeau for that decisive action. I had talked to Justin Trudeau ahead of the election. He did not even call me to let me know that this was going to go. And indeed, he fulfilled his promise. I am really grateful for that. Now, the reality is that these kind of things take a lot of focused effort. And unfortunately, our political leaders are good at making promises, but they're not very good at keeping the focus and eventually delivering on those. And so we are currently in a lot of trouble.
Yeah, I see that the stats, HIV was relatively stable from 2013 to 2019, but since 2021, the cases have been increasing, right? It's a 6.1 peak, 6.1 per 100,000 in 2023. It's a peak. Can you explain why we're seeing these tide of rising cases
again? The problem is that we have the same situation that I described for South Africa, vis-a-vis why is it not working in South Africa and when it's working in British Columbia, is what happened in Canada. So our government, largely because we are here and we were putting a lot of pressure and a lot of data in front of them to justify this movement, our government in British Columbia has been very proactive. And therefore, we have been very successful at bringing down HIV. As you know, in 2023, we declared the epidemic phase of HIV/AIDS in British Columbia over. We closed the AIDS war 10 years ago or more. We declared the end of the epidemic, and we were very happy, and we were moving on to other things. When unfortunately, we started to realize that our numbers were starting to creep up. And when we look into that, the obvious reason was that we were having a net migratory pressure of cases coming from the rest of the country. And when we look further into that, while the cases in British Columbia by 2023 had decreased markedly, more than 90% decrease in morbidity, mortality, and transmission from the peak of the epidemic, there was no evidence of any significant decrease in HIV incidence in the last 10 years. And in fact, there had been a 30% increase in national cases across the country, despite the success of British Columbia. And the reason for that is that the rest of the country has failed to meet the 90-90-90 threshold by 2020. And in fact, they're not going to meet the 90-90-90 threshold by 2025, which by now it should be 95-95-95. And when we look further into this, the problem is that political leadership across the country is not in agreement as to what the way forward should be. Some of them don't care. Some of them, they care about the epidemic in some areas, but not others. And in all honesty, as you heard from Lynn's excellent presentation regarding measles, when it comes to infectious diseases, you cannot have pet favorites. You have to have an approach where you treat everybody the same. We need to be in every corner all the time, and there are no exceptions. Because if you apply exceptions, the pathogens will take advantage of that, and they will procreate and eventually come back. And so this is what we were experiencing prior to this year, when things became even more complicated.
I know you were on the interview with Stephen Quinn on CBC, and when he asked you whether you're hopeful that Canada could control HIV again, given the measles comeback, you stated that you're hopeful that Prime Minister Mark Carney could step up. where America had failed and create a pan-Canadian solution or strategy. What kind of strategy? What would the strategy look like?
Well, so let me pick up at the beginning. Yes, as you pointed out, I have been quoted saying I was hoping that Prime Minister Carney will understand the significance of the rising numbers of cases of HIV in the country, and therefore it would act decisively to make this a priority. So far, it has not happened. Beyond that, he has not really delivered on the funding of the Global Fund and other international agencies. We can discuss that further in a moment. From my perspective, I think Canada is missing the opportunity to play a global leadership role in taking what it is a Made in Canada strategy, demonstrate that it actually works without a whole lot of effort, to be honest with you. And in doing so, if and when the rest of the world wakes up or reawakes after the Trump nightmare, we may be able to take advantage of this knowledge and ensure that we regain the lost terrain in our fight against HIV/AIDS. The elements that we need for Canada to control HIV are fairly straightforward. First and foremost, you need to have full access to free antiretroviral therapy for those that are infected with HIV, and for preventive antiretroviral therapy or PrEP, pre-exposure prophylaxis, for individuals who are at high risk for HIV infection. That is to say, people who are known to have had contact with people with HIV who are viremic, or people who have a recent history of sexually transmitted infections. If you do that, what you need to understand is treatment and PrEP are synergistic against HIV new infections, so that while, as Lyng indicated, it's very difficult to meet 100% of anything in any area of public health, if you reach 90%, let's say with antiretroviral therapy, and you reach about 90% of those that need to be on PrEP or pre-exposure prophylaxis, we have shown that the ability of the virus to expand when you are performing at that high level is truly minimal. So first and foremost, free treatment and free pre-exposure prophylaxis. Second, we need to have a harmonized monitoring and evaluation of the strategy at the global level. And failing that, at the very least, within Canada. The Public Health Agency of Canada at this time only reports the progress towards the outcomes that we indicated, the 90-90-90 or 95-95-95, every 2 years. And when they report at least a year late. So imagine we'll hear from Victor regarding COVID, or we heard from Lyng regarding measles. Imagine if I were to report COVID or measles every 2 years, you would be basically in the dark. Well, that's exactly what's happening in Canada. We need, in addition to that, to monitor the genetics of the virus, because that allows us to know how the virus is evolving and where the clusters of transmission are occurring. So we use phylogenetic monitoring to identify with great degree of accuracy where the HIV transmission is occurring, so that we don't have to throw resources all over the place, but actually we can be very focalized where you apply those resources with high degree of efficiency. In addition, we need to harmonize risk reduction practices. Everybody knows around the table that harm reduction is very useful, whether it's in the injection drug use or the sexual risk. And we're still having difficulty agreeing what minimum harm reduction practices should look like for sex, for drugs, etc. We need to stop worrying about the political correctness and realize that these are health matters, and that we should be at the table dictating what this should be like across the country. We cannot have the Alberta government deciding that harm reduction looks like A, while BC looks like B, and the Quebec, it looks a French version that it has nothing to do with evidence. No, all of that has to stop. We need a national harm reduction strategy, and that's the end of it. One more thing, we need to stop the over-criminalization of HIV transmission. Every politician that I talk to, and believe me, I talk to all of them, they tell me, yes, Julio, this is a problem. Imagine this. in the early days of the epidemic, new laws were put in the books whereby if I am an HIV-infected individual and I have undisclosed sex with another person, man or woman, whatever, even if HIV transmission did not occur, I can be sent to jail and labeled as a sex offender for the rest of my life because I did not disclose. Fine, if you wanted to argue that that was okay for 30 years ago, okay, we can discuss it, doesn't matter. But one thing is for sure, it is not right for today. Why? Well, because sexual assault is sexual assault. And if I'm taking antiretroviral therapy, I am not infectious. We have a situation where we recognize that undetectable in the blood means that you are untransmittable when it comes to sex. So having people criminalized by having sex when there was no, first, HIV transmission did not occur, and second, there was no chance that HIV transmission could occur, is actually highly unfair. Not only is unfair, but this acts as a deterrent for people to come forward and to be willing to test because they recognize that there could be a legal jeopardy. So every attorney general, going back 15 years, has agreed with me that we need to change this. And yet nobody has changed it. Who is paying the plate for that? My patients. And those that should be my patients that are afraid to become my patients. So we need to change that. Finally, we need to enhance social and medical supports. People living with HIV are disproportionately individuals from First Nations, individuals from poor socioeconomic situations, marginalized communities, migrants, and increasingly so, migrants and refugees from developing countries. We need to take a comprehensive policy that will help all of them.
That's fascinating and really totally agree with everything you said. Now, one of the new things that come on the horizon is a new drug, lenacapavir. It's a twice-yearly injectable medication, and it's been adopted as a treat-as prevention protocol in some countries like South Africa, where 1 in 5 people have HIV. Can you tell us whether you think that this might be a helpful solution to Canada and worldwide?
So, Susan, I'm the last one to argue that research is not important, that new drugs are not necessary, that new developments are essential. Of course, we need a cure, we need a vaccine, we need a whole lot of other stuff. But let me remind our audience that everything that I described was achieved in British Columbia before there were any fancy long-acting antiretroviral therapy drugs that, by the way, currently cost in the order of tens of thousands of dollars per year. How many tens of thousands, I cannot tell you because it's changing every day, but it could be $60,000 a year, $50,000 a year, $40,000. It doesn't matter. With that kind of money, I can treat tons and tons of people with generic medications. In fact, that's what we're doing. So we are being very responsible how we approach this problem. Don't get me wrong. If there is a medical need for people to take long-acting agents, we will make it available to them through our program free of charge. But we are being very cautious. Our healthcare sustainability is an obsession of ours. In fact, treatment as prevention drives disease elimination, which in turn is essential for healthcare sustainability. And I am trying to encourage people in all disciplines, not just infectious diseases, to think carefully about how this paradigm can be applied to their practices so that we together can diminish the pressure that the healthcare system is suffering. So I'm the last one to say, okay, let's take a shot at the lenacapavir at several tens of thousands of dollars per year and replace, say, Truvada, which costs cents a day, for equally highly effective if you take it every day to prevent HIV infection in the case of PrEP, or equally effective at other treatments for the treatment of people infected with HIV, and save that jewel of the drug, which is no doubt very valuable for individuals who truly medically need it. I had an experience a couple of years ago. We became concerned that the Americans were becoming too distracted in regards to the HIV strategy. And so we brought the PEPFAR people and the Global Fund people and the CDC people from the United States all together here to have this conversation. And I was impressed, not favorably necessarily, how much they were putting their hopes that the new drugs were going to solve the problems that they were not able to address with the simpler, cheaper medications. Well, guess what? It didn't happen. Not only didn't happen, but then Trump happened and everything fell apart.
Can you explain to the audience who don't know what PEPFAR is, PEPFAR was, I believe it was 2003 by President George W. Bush. Can you tell us what that program was and how it helped and why everything is under threat now?
So, as you will remember, in the early 2000s, morbidity and mortality from HIV was a major global concern. Even though we have been making progress in North America and other developing nations, the south of the world was being devastated. And Colin Powell, at the time, who was the Secretary of Defense, if I remember correctly, or something of the kind, he came to Bush and he said, Mr. President, HIV/AIDS is the global most important threat to security. We need to do something about it. And the Americans created the President Program for Emergency Relief, blah, 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 whatever. And that's PEPFAR, President Emergency Program for African Relief. That's it. And so PEPFAR became the flagship for the American investment in the south of the world, predominantly in Africa, but not exclusively, Latin America, Asia, Eastern Europe, etc. And this program has been fantastic. And we actually worked very closely with them, and they were among the most enthusiastic endorsers of our treatment and prevention strategy. And we're very grateful for that. This program was distributing funds all over the world, and it worked in tandem with the Global Fund, which was a G7 sort of repository for resources, whereby Canada and other G7 countries can contribute and synergize with the PEPFAR program. Lo and behold, not only HIV, but malaria and tuberculosis were also targets of these programs, the PEPFAR and the Global Fund. Lo and behold, President Trump came around, and in his own wisdom, or lack of it, I'd rather say, he decided that he was going to pull the plug on the overseas global support for health and the likes. So much so that the funding for global health that the Americans put forward decreased by nearly 80%. And in effect, not just HIV, which decreased by more than 70%, but it actually affects mother-to-child programs, family planning, malaria, tuberculosis, nutritional programs. And these programs are all synergistic. They work together. And you cannot have one without the other, because these diseases are syndemics that work together, in this environment. So we need to address them all together. Well, he announced that in the first quarter of this year. John Cohen from the journal Science called this a potential bloodbath. And in all honesty, I think he's totally right. We expect that this program is going to give rise to massive increases in HIV, both new infections and death. If in fact, this chart speaks by itself, it's likely that the rebounds on mortality and transmission will take us back to the peak of the epidemic some 20 years ago. Within a matter of months, we will be in a disaster. And unfortunately, I'm telling you, we are already seeing that the number of new HIV infections in the province in British Columbia here today have more than doubled. And when we do phylogenetic assessments or sociodemographic assessments, all of the excess HIV that we're seeing is migratory. A large proportion of them are coming from abroad. And I am not calling to stop refugees and migrants from coming to the country, because let me be very clear. In British Columbia, we offer these people treatment the moment they walk into the province. And as a result of that, our phylogenetic monitoring shows and demonstrates unequivocally that these individuals coming to the province, they don't transmit. Not only they don't transmit, they don't get sick, and they contribute to our society. So that is not the problem. The problem is that we need to offer them the services that they need back at home, so that we decrease the migratory pressure that the absence of services is generating. And unfortunately, much that I lobbied the federal government to keep this in mind when they made their announcement a week ago regarding the Global Fund contribution that Canada is making this year, sadly, our contribution this year, for the first time in 20 years, will be decreasing by approximately 16%. Granted, it's not the kind of decrease that the Trump administration is proposing, but nonetheless, against the background of the decrease that we're experiencing because of the American decisions, or lack of the wisdom, our cuts in funding are going to do nothing but make the situation worse.
Yeah, this is extremely heartbreaking to hear this.
It's devastating, Susan.
Yeah,
I dedicated 40 years of my life to find a solution to this problem with great success, only to arrive to the deadline. We're almost ready to deliver on the promise of the strategy for the Americans to pull the plug and for Canada not to have the courage to step up to the plate and compensate for that deficit.
Yeah, that is a very concerning and very devastating thing. I totally agree. Now, are there any other areas that you feel that if we did a strategy of treatment as prevention, we could help these diseases in BC and Canada?
Well, as I pointed out earlier, treatment and prevention simply means that if you have a highly effective therapeutic strategy, and that could include anything from education to vaccines to treatment to whatever it needs to be, and then you have a population that needs to access those services, but somehow cannot find its way to it, what we are trying to do with treatment and prevention is to bring these two things together. We study the treatment, we study the population, or populations, because often it's many different sectors of the population, and then we try to create a specific strategies for each one of these groups that need to access the treatment that is culturally adapted to the circumstances of those individuals. If you think about it, this can apply to any infectious disease. Hepatitis C, we're doing that already. Sexually transmitted diseases. But in addition, it can apply to diseases what we call of social contagion. And that is the case for diseases related to overeating. Think about high cholesterol, think about obesity, think about cardiac disease, or diseases related to the habit of smoking, or related to the habit of using drugs. Why? Because there is a social contagion that we have shown is operational in these conditions. And the contagion is important because the increased return on investment related to treatment and prevention is driven by the additional preventive value of the strategy. So in other words, if you find a group of people that need a particular intervention and you have that intervention that affects morbidity, mortality, transmission, rest assured, bring it to me and I'll show you how. You are going to demonstrate that this should be to the front of the line because this is going to save you morbidity, mortality, transmission, and as a result, it's going to save you money. We have done this. Let me show you. We have done this for example, syphilis in our program. I won't go into the details, but we are also offering doxycycline for prevention of syphilis, gonorrhea, and chlamydia to patients that are enrolled in our treatment or PrEP programs. Without going into the details, you can find all of the information in the BCCFE website. And what you see here is that immediately after they start the doxycycline treatment at this point, when you compare the rates of syphilis, in this case, before they started doxycycline, and after, we see a greater than 70% decrease in the incidence of syphilis. Similar response has been obtained in our program here provincially for chlamydia. Not so much for gonorrhea, which is similar to what's happening in other places, and therefore we're contemplating adding yet another therapeutic element that will be more specific to gonorrhea. More on that in due course. The big good news is that we can do this as a systems approach across the whole BC environment. And if we do that, we will be strengthening our healthcare system in addition to the health of our peers.
Your plan sounds like a very viable and very sensitive solution to our problem. I hope our governments will listen to you and put your thoughts into action.
I'm happy to say that they are, and although it takes a lot of work and time, we are moving forward with treatment and prevention for HIV, hepatitis, syphilis, gonorrhea, and chlamydia, and more recently, COPD, type 2 diabetes, and next, addictions.
Thank you, Dr. Montaner, for everything you're doing on behalf of all British Columbians. Thank you so much.
Thanks.
For our next section and our last discussion, we have Dr. Victor Leung, He's going to discuss the COVID-19 pandemic and the public health response based on Dogma. So thank you very much. Dr. Leung, I would like to thank you again for being one of the most respected voices standing up against dogmas of BC public health during this ongoing COVID-19 pandemic. Your actions during the pandemic have prevented many people from becoming sick and dying. So, Dr. Leung, early on in the COVID-19 pandemic, there's already mounting scientific evidence that COVID-19 was an airborne disease. The Lancet, May 2021, published an article on the 10 scientific reasons why COVID-19 is airborne, authored by some of the most respected aerosol scientists, Jose Jimenez and Kimberly Prather. What are some of the evidence early on that COVID-19 was an airborne virus?
Thank you, Susan, and good afternoon, everyone. Hard to follow Julio's energy and his accomplishments and leadership, but we're going to switch topics and talk about COVID. And to address your question specifically about the WHO's failure or delay to acknowledge the predominant transmission route for SARS-CoV-2, it wasn't until December 2021 when WHO, the World Health Organization, used the term airborne officially in their guidance for protection and thinking about how we can dedicate resources to improving the prevention of transmission of SARS-CoV-2. I don't work at the WHO organization, but in speaking to colleagues who have worked, it is a large, complex organization, and there are many different subgroups with different expertise that provide guidance. So an example is that maybe the infection prevention and control expertise group at WHO could have provided guidance that's different than some of the other groups. And ultimately, when it comes to presenting a message and communicating to the public, that falls upon the Director General, as well as based on advice from their risk communication specialists. What I can say is that they have taken many positive changes, but when we look back, and looking back is difficult to say what was done correctly at the time or not, but looking back at how transmission was communicated, there was a lot of evidence early on from the pandemic that we should have taken a different approach and implemented measures for airborne transmission. We know that even prior to COVID-19 first cases, there were many different pandemic playbooks that focused on pandemic influenza. And although some of those practices and strategies in the pandemic playbook for influenza could have been deemed as incorrect measures when we apply it to a respiratory virus like COVID-19, even in the pandemic playbooks there was a focus and emphasis on taking a precautionary principle, meaning that when we are encountering a potential pandemic influenza virus, the measures that are in place need to address the riskiest routes of transmission, which was airborne, and that measures needed to be in place to expect supply chain deficiencies or challenges in infrastructure in hospitals, for example. And so contingency management plans were there. But what had happened at the beginning of the pandemic was a quick shift by many countries to move away from that recommendation from the influenza pandemic playbook to treating transmission like seasonal influenza. And I think that's one of the biggest mistakes that was made during the pandemic. And that was also recognized by their chief scientific officer when she left the position. She said that one of the biggest regrets in that time was the ongoing debates about transmission and not explicitly recognizing airborne transmission earlier. That was reiterated by the current chief scientific officer at the WHO, Dr. Farr. And so I think there's been a lot that was learned, but definitely looking back, there was clear evidence that was there from early transmission, epidemiology and outbreaks, that this was predominantly transmitted through inhalation.
In July 2024, you gave an excellent presentation on pathogens that transmit the air, challenging infection prevention and control dogma. Can Can you tell us what dogma is, and maybe the excellent example of dogma with the case of Dr. Barbara Warren and Helicobacter pylori?
Yeah, so I think dogma is an authoritative opinion, or a prevalent authoritative opinion at the time, and many things lead to this authoritative opinion. But what's key about dogma is that it's often not supported by good evidence. And so these authoritative opinions have a lot of weight in our ideas and approaches to dealing with infections, for example. And one of these examples I presented was Dr. Robert Warren and Marshall's Nobel Prize winning accomplishment and contribution to our understanding now of how Helicobacter pylori, a bacteria, is a significant primary cause of gastric ulcers, duodenal ulcers, or peptic ulcer disease as we know it. Prior to this, the scientific medical community had always said that it would be a peptic ulcer disease is caused by things like stress, and that there is no way that a bacteria could be the cause of this. Now their finding dramatically changed our scientific, our medical thinking, and our treatment approaches now. When I think about how dogma applies to infectious diseases and how infectious disease community responds to this, we see this in our approaches to treatment of many common infections. So it used to be a predominant dogma was that people with bloodstream infections must complete their treatment with intravenous antibiotic therapy. Now there's clear randomized controlled trials that show how we can safely transition to oral antibiotic therapy, eliminating the need for an IV catheter and improving safety and outcomes in individuals using different treatment approach. And so that challenged, that evidence changed our way of thinking and challenged that dogma. Another thing that's we're getting increasing evidence on now is duration of treatment of common infections, like urinary tract infections, pneumonia, and so forth. Used to be that people dogmatically said we needed 7 days or 14 days of treatment for these types of infections. And now there's increasing evidence for many of these infections that using shorter courses of antibiotics are as sufficient to treating these infections. So that's kind of the example of dogma, and how it relates to COVID-19 and transmission is when I trained and came out of training from infectious diseases and microbiology, the predominant dogma was that respiratory viruses are transmitted through large droplets, and that the biggest risk of transmission is when we're in close proximity to each other and these large droplets land on our mucous membranes or are transmitted through our hands. It's now scientific consensus published in Nature in 2022 that many respiratory viruses, specifically SARS-CoV-2 that they looked at, scientific consensus is that this is transmitted through inhalation of much smaller particles. And the WHO, to the credit, has changed some of their communication and has started collaborating with other experts. In the last 2 years, the World Health Organization worked with the CERN, or the European Organization for Nuclear Research. They have expertise in particle physics, and what they've produced collaboratively is risk assessment tools for organizations, buildings to look at to improve on air quality. And that will not only reduce risk of respiratory virus transmission like SARS-CoV-2, but also improves other aspects of health when we have good indoor air quality. So I think we are making progress with science to challenge dogma.
That's very fascinating, Dr. Leung. It's very interesting because in BC, when I go into hospitals now and I'm seeing my patients, when there's a COVID-19 outbreak, we know it's a respiratory virus, but yet we're using droplet precautions still. There's curtains being drawn around patients and hand washing as the main strategies to control infection. So can you explain why this is still going on in BC?
I think part of it is that we are slow sometimes to change, and we know what's the right thing to do, but maybe due to constraints, healthcare resource constraints, or different approaches to risk communication, we're not necessarily doing all we can to prevent transmission. It's not to say that focusing on cleaning hands is not important or maintaining a safe environmental surface is not important, but when it comes to risk communication and infectious disease transmission, my approach would be to focus on the facts about how we can best prevent transmission and deal with the resource limitations afterward. So my recommendations when we deal with respiratory transmission are always focused on thinking about how we can apply the measures best to reduce the predominant route of transmission, which it is through inhalation of smaller particles or aerosols. And we don't have to have, like mentioned previously, 100% gold standard, but we can do other measures that can still reduce the risk of transmission through blocking the chain of transmission, which in this case, in an outbreak setting, when you have high prevalence of infections and circulating virus in shared airspaces, unless you have all the environmental measures that are in place, which we know is not feasible in many cases to retrofit, you have to improve those measures using engineered infection control measures like portable HEPA units to help filter the air, like using better respiratory protection like respirators, and not reducing our measures to suit a narrative that is outdated in terms of how we classify disease transmission.
Thank you for that answer. So this is kind of leading to our next question. So in August 2025, the British Occupational Hygiene Society officially recommended the use of respirators instead of surgical masks in healthcare settings. And the CSA has a new proposed standard Z94.4 for the use of respirators in healthcare settings. Yet in BC, currently N95 masks are only stated to be used for aerosolized generating procedures, medical procedures. And some of the top IPAC people were against the new Z94.4 standard from the CSA. Can you explain this?
So just some of the terminology. So the CSA, or the Canadian Standards Association, is one of the largest standards association in Canada. It is for each of the areas where they produce guidance. It is with multidisciplinary experts who recommend measures that are considered the best practices in safety, quality, and they cover many areas of industries, including healthcare. And their recommendations are not legally bound unless it's incorporated into the laws. When we think about CSA and how it's been used in healthcare settings, for example, we refer to it for looking at hand hygiene sinks as an example. What do the sinks need to have in order to enable people to clean their hands, reduce risk of transmission? And so these standards are used in healthcare facilities for many years. In fact, with new hospital builds, CSA standards are first kind of the terms of reference. And if there are supposed to be changes that don't meet those standards, there needs to be good reasons for multidisciplinary groups to think of why the practices should deviate. So currently the CSA is producing standards for use of respirators in healthcare settings, and it largely matches what the Occupational Health Society, the British Occupational Health Society, is recommending. I think the differences in approaches of adopting it or refusing to adopt those recommendations has to do with different expertise. For example, I'm not trained in occupational health, so when it comes to occupational health recommendations, I would defer to occupational health hygienists and specialists in that area. But that may not be the case in all jurisdictions. Sometimes one group is given decision-making capacity over another when it comes to healthcare worker safety. And so my opinion on this is that when it comes to occupational health, we should defer to occupational health experts.
Thank you very much. Changing topics a bit, at the recent Global Security Forum held at UBC in November, a BC mental health officer said that children were not transmitting COVID from schools and community, and children did not get very sick from COVID. Can you comment on this?
So I wasn't at the meeting, so I don't know the specifics of what was said and the context, but my understanding, like all respiratory viruses, children certainly can be infected and do have a role in transmission. I think during the early days and years of the pandemic, some of the issues get conflated, that if you say that children are part of the chain of transmission, that then you must close schools. And that's not what I'm advocating for. What I'm saying is that we have to recognize who is at risk in order to have our measures prioritized to the most vulnerable. And to say that that children are not at risk of acquiring COVID or transmitting COVID is I think, not substantiated by evidence.
Thank you very much. So the World Health Organization has estimated 154 million lives have been saved worldwide by the COVID-19 vaccines. And when they first arrived, people were clamoring to get vaccinated, but vaccine rates have been increasingly waning. And currently in BC, only 30% of adults are getting vaccinated and less than 10% of children. So why are we seeing this hesitancy of vaccination for COVID?
I think, yeah, it's a very complex problem that there's many sociologic factors associated with that. But if we just look at the evidence supporting repeated COVID vaccinations, I think it's important to recognize we don't have randomized control trials to look at people who have been multiply infected or infected with COVID multiple times or have received multiple vaccines and have had COVID as well. And that level of protection that may infer. What we do know is the virus mutates, and mutations may not be predictable in terms of its impact. And so the current recommendations in many jurisdictions is still to have updated vaccines prioritized to people who may be at the highest risk. And I think that with everything else that's happened with the pandemic, that certainly has influenced people's decision or potentially fatigue in hearing about vaccines, leading to a lower uptake, along with the lack of the data currently to support this from a randomized control trial level data. However, I think that it still is important, as Lynn mentioned, the other strategies to focus on, that we can't assume that just because someone is more reluctant to get a COVID vaccine or clearly doesn't want to, that it means they won't be open to having conversations about other vaccines. So vaccine preventable diseases, there are many, and we just need to focus on how we can improve vaccine confidence and uptake in other diseases.
So one of the things that has been happening during this pandemic, there's been a lot of mixed messaging to the general public by health authorities. They're encouraging people to become vaccinated, but at the same time, going on radio to say that COVID is just like a cold. Do you think the mixed messages given by public health has led to increasing public distrust for recommendations for vaccine and masking, and why, and what can be done about it?
Yeah, I don't think I could offer much expertise in this. The communications is a specialty, and risk communication is a subspecialty in itself. I think when we look at risk communication, some of the principles that organizations like the WHO follow include basic principles like establishing trust, communicating things in a timely way and early during emergencies, full disclosure to enable transparency, and involving the public. So with the way the public can receive information now, the multiple modalities and how people communicate with young people and different communication strategies there, I think that it is very hard when there are many different messages, and there's pros and cons of having just one message being communicated. So I can see the challenges that organizations and public health face in this area. One of the things that I think large organizations like the WHO has done is, or at least some of the members, like their chief scientific officer when she left her post, and the incoming chief scientific officer, is admit to the errors that have been that have occurred, because we know errors, human nature. So admitting to the errors and thinking and reflecting on how those errors can be avoided in the future. So that then relates to future pandemic plans and what we've learned from COVID. Those need to be incorporated, and especially, I guess, in the area of communication, a good relook at what are the modern ways of communicating to influence change. And that's an area that I defer to the communication experts on.
Yeah, I totally agree. So I know after SARS-1, there was a Royal Commission, and that currently the UK this past spring, there's a commission inquiring about mistakes during the current COVID-19 pandemic. Is there any other things that you think should be some key recommendations that should be made if there was an inquiry into the current COVID-19 pandemic?
So the UK has completed their multiple modules on their inquiry, and there's many lessons learned there. After SARS-1, we had our own inquiry in Canada. I guess the first things that come to mind would be the precautionary principle when we're uncertain of how things are transmitted or the disease severity, to have an impact on potential impact on reducing risk of transmission early on in a pandemic, for example, would be vital to ensuring that we've learned from some of the mistakes during this last pandemic. And there are many lessons that can be learned in various areas, whether it be workplaces and employees who are most vulnerable, and the impacts on children, elderly, and so forth. So lots to learn, and we don't necessarily need to do our own inquiry. I think we can learn from the inquiry that's been done in the UK, although many different political contexts there, but definitely lessons that need to be learned and followed when we develop our updated pandemic planning across the globe.
Thanks very much, Dr. Leung, for such an interesting discussion on COVID-19.
Thank you.
Thank you very much. We'd like to invite Dr. Filiatrault and Dr. Montaner to come back again. And so measles cases are rising exponentially. COVID is not over, with the virus continuing to mutate and outbreaks continue to occur. And HIV cases are projected to increase with loss of US foreign aid. This is largely stemming from a global rise of anti-science ideology and current right-wing political climate. I would like to ask each of you what we can do to stop this tide. I'll start with Dr. Filiatrault. And Dr. Filiatrault, I'd first like to thank you very much. Your quick thinking in 2003 really averted the devastating effects of SARS-1 on BC and Canada. So thank you so much. So so worldwide, the rate of vaccine hesitancy in child vaccines, including measles, is increasing. So what can we do to turn the tide in Canada and the world?
So let me just pick up on what Victor said. So back in 2003, it was a constellation of, it's a little bit like the Swiss cheese model. And it was the quick action and preparation that allowed me to recognize that the patient that came in at the end of my shift could potentially have a communicable disease that we didn't want to spread, neither in the department, my colleagues, other patients, and else and in the community. So I didn't know at the time of the precautionary principle, but I'm trained in eMERGE that you rule out the worst case scenario. And the worst case scenario was that this was airborne. And so that's why, you know, BC CDC, epidemiology lead for influenza and emerging respiratory pathogen, had sent an email and to infectious disease, medical microbiology, labs, public health, and emergency departments across BC. And so it was the preparation, the anticipation, sending the email, reading the email, and then realizing I'm not sure what this person has, but he's just come off the plane from Hong Kong and he's sick. So, and it was also the timing. We were in 2003. We didn't have jam-packed emergency department where you're seeing people in a waiting room, sitting on a chair, or in a hallway, in a cubbyhole. And so it was all this that needed to come together to say, okay, let's take this seriously, let's act, and let's move the person who's in the isolation room and put my patient. And so, you know, if there's one lesson, there's many, but this one should be embedded, the precautionary principle. And the reason I bring it up is we have H3N2 going on right now, right? Spreading. I'm looking at the wait time, 7 hours right now for BC Children's Hospital on a Thursday afternoon at 3:30. And we knew, because the same person who sent the email back in 2003 raised the alarm on April 1st, published a paper on October 28th saying, we've got a problem. The H3N2 has mutated during the Southern Hemisphere flu season, and it's spreading in Asia. And then on December 1st, she called a meeting from the BC CDC and stated, we can't just look in the retrovisor and say, oh, yes, this was a problem. We have this data right now. We know it's spreading in UK, it's spreading in Asia, and we have a population that's under-vaccinated. What could we do? We don't have masking in healthcare right now. So a family in the waiting room at BC Children right now, if they go in for musculoskeletal injury, will leave possibly with influenza. So to me, we need to have really a rethink about public health. And public health was always about going upstream. And right now, public health is reactive and reactive after the storm hits, right? Mm-hmm. So what's the point having surveillance if you're not going to act when the people say, hey, we've got a problem. Look at what's happening in the world. And here we are, didn't act. And, you know, the vaccination for flu is poor, even amongst the over 65, and especially about in healthcare worker, I'm ashamed to say. Healthcare worker, many elect not to be vaccinated. And if there's a year to vaccinate, it's this year. So that would be my answer. I know I'm not answering the question, but I'm feeding on Victor's point. The precautionary principle, the Archie Campbell report, SARS Commission, wanted it to be a guiding light for public health, for healthcare, and pandemic preparedness. And we're having to relearn this lesson because we're not learning it. We're ignoring it, and it's here again. And next time it'll be maybe avian flu, lo and behold.
Yeah, that's a great answer, Dr. Filiatrault. I think we all agree with that. And I know, Dr. Montaner, you have told us that if they would go back to basics, it's not the fancy vaccine, it's not the fancy expensive drugs, but go back to basics. That is what is going to help prevent some of these diseases, right? And so one of the things that we are challenged with right now is that we are living in a time of science of information, and some of the most reliable sources of scientific information, like the US CDC, are no longer reliable. So where can people get accurate scientific information?
Well, Susan, this is becoming a huge problem. To illustrate that, we recently had communications with our colleagues in the United States with the gutting of the US CDC by President Trump and a number of other agencies. Colleagues in the Northeast and the Northwest and the Pacific coast have started a conversation whether we should try to develop a separate initiative to take over some of the responsibilities that the US CDC had in terms of guidelines and the like, to as a service to communities in general, we could bring our guidelines together with those of other sort of progressive institutions around the continent and offer a repository of guidelines. In the meantime, for anything related to HIV, the BCCFE has a comprehensive set of guidelines in our website. Those are guidelines that we generate here in BC. They are BC specific, and they adapt perfectly well to all of the programs that I described and many more. So I encourage people to visit our website. The CDC in British Columbia has their own set of guidelines and information, which I think still quite reasonable. But in all honesty, this is a gap at the moment, not only because the US CDC has sort of fallen apart, but the problem is that there are many other sources of information that are not appropriately vetoed or taken care or curated. And as a result, I ask people to be extremely careful.
Thank you so much for all your answers and for everything you're all doing for the health of everyone in BC and the world. Canada and the world are now facing conversion crises. Measles cases are on the rise, and we are seeing cases of HIV climbing because of cuts to budget and USAID around the world, and COVID-19, the pandemic, is ongoing. So the question I ask for all of you, and this is what we like to leave our interviews with, can you tell us, each of you, what gives you hope to continue doing what you're doing? And can you give us hope for our listeners?
Well, my hope, if I am allowed to start, is that, there are, as we often say, there are the good years and the bad years. And unfortunately, the good years and the bad years tend to alternate. Sadly, lately, we're getting a lot more bad years than good years. So I'm hoping that this bad years section, which we're really going through courtesy of the United States of America, in a large part, are going to see an end pretty soon. I'm hoping for the midterms, but if not, within the next 2 to 3 years. And I say this with all due respect. I'm not trying to be political about it, but our world has turned into a nightmare as a result of what's happening in the United States. The RFK Jr. influence on the health programs in the United States cannot be underestimated. The guy is a threat to everything that we know. He should be gotten rid of at the earliest possible time. And we need to support any efforts to have this individual removed from a leadership position. He is absolutely devastating. He's doing everything in his power to undermine these agencies. I don't know what their final objective is, but it's no good. There is no doubt about it, and we need to get rid of them.
What about Dr. Filiatrault and Dr. Leung? Things that give you hope and can give hope to our audience.
Well, I think we definitely have to keep the light on and hope. The pandemic has really changed all my thoughts about medicine, and there was a lot of things that I used to take as dogma. Okay, infection control tells me to do this, it must be right. And now I'm looking at the evidence, and I'm more questioning, and I hope we're going to have a culture change in infection prevention and control. And if we do, you know, if we have a clean air, indoor air revolution in schools, in hospitals, there's a lot of nosocomial infections, so hospital-acquired infections, that could essentially be wiped away if we address the real mode of transmission. So my hope is that eventually we, you know, bridge the resistance, break the wall of resistance, and healthcare can really take this on and be part of a clean air revolution, really. And then we will be in such a better place and be more, and have to spend less on healthcare harm and have more money for other important projects that Julio has.
And Dr. Leung?
I think two things give me hope when I see patients and talk to them about prevention of infections and approaches. Lucky to have people still want to listen and try and have good uptake of vaccinations that we provide. The other, I guess, thing that makes me hopeful is learning from people like Lynn and Julio, their perseverance, resilience, and focus on encouraging and speaking up and doing the right thing. Gives me hope because I think they have influence on many of the other people that have trained with them or are coming into the area, into the field of medicine. So thank you.
Thank you so much. Dr. Carl Sagan, despite his predictions, still believed that science was a candle in the darkness. And if we based our decisions upon science, there would be hope for the future. The three guests in our panel today are themselves examples of the ray of hope with what they have accomplished and what they are continuing to do, as exemplified with this quote by Edward Everett Hale that I heard on the Austrian Report podcast. I am only one, but I am one. I cannot do everything, but I can do something. And because I cannot do everything, I will not refuse to do the something that I can do. So thank you all so much, Dr. Filiatrault, Dr. Leung, and Dr. Montaner, for joining us today on this POPBC briefing. And thank you all for everything you're doing. And thanks to our listeners for taking the time to listen to this briefing.